first thing is that the kidneys don't like hyperfiltration. The glomeruli hate hyperfiltration. Why? Because it kills them off. A hyperfiltrating glomerulus is not going to survive. So now, if you see the left-hand side, you have a big arteriole getting blood into the glomerulus, which is in brown, and a small efferent arteriole taking the blood away. So now you can imagine that there's a lot of blood going into the glomerulus because more is going in, less is coming out, so there is hyperfiltration. Now, this hyperfiltration means that a lot of glomerular filtrate is now going into the tubules. Okay, now this can be addressed by SGLT2 inhibitors, example, wherein even more glomerular filtrate is there because of lack of reabsorption. Now, this enhanced glomerular filtrate, as it goes down that long path of the tubule, there is a part of the tubule where it is in close proximity to the glomerulus. And you can see that in sort of pink. Now, that is called the macula densa. Now, what happens when the macula densa sees that there's a hell of a lot of glomerular filtrate coming in, then by various autoregulatory mechanisms, the hyperfiltration comes down. It takes a little while. It doesn't happen immediately. So you have hyperfiltration. The hyperfiltration is enhanced by, say, SGLT2 inhibitors. And then that excess filtrate is presented to the macula densa, which realizes, oh, too much of fluid is there, too much of filtrate is there. So cut down on the glomerular blood flow. And that actually saves the glomerulus because, as I told you, the glomeruli hate hyperfiltration. The same thing happens with ACE and ARBs, you can see on the other side, where what happens is that the efferent arteriole is dilated with ACEs and ARBs. So once that happens again, the pressure on the glomerulus comes down. Now, just to take it a little bit further, the number of nephrons are fixed at birth. And once the nephrons are damaged, what's happened is that the blood flow to the kidney is the same. So now that same blood flow is being inflicted on a fewer or a lesser number of glomeruli. So what will happen? They'll all get hyperfiltration. And what will happen with the hyperfiltration? Podocyte stress and loss is the earliest thing. And ultimately, it's a goodbye to the glomerulus. And so this, as you can see, is a sort of a negative feedback type of thing. And there's a tipping point at which, after a certain number of glomeruli are damaged, the rest are so much subject to hyperfiltration that no matter what you do, there will be progress of nephron loss or glomerulus loss. Now, now we come to another philosophical question. Is aging a disease? I thought aging was a disease 30 years ago. Now I think aging is not a disease, and for obvious reasons. Well, as you can see, this is how the eGFR falls with age. At the bottom you have the age up to 85 years, and you can see the blue line and the red line basically showing that how the glomerular filtration comes down with age, and this is a normal process. Now, we'll come back to that later. Now, this is a very, very interesting slide I found out while researching for this talk. And here, what they've done, looking at 6,000 patients in Hong Kong, they found that the decline in eGFR is not homogeneous. And this is something that we see all the time. Not every patient whose eGFR, say, is compromised a little bit is going to, decline at the same rate. You can see the blue one, the decline is less. There's another one where the decline is sort of S-shaped, and there's a green one where the decline is very rapid. Now, this is something that, I personally intuitively felt for a long time, and I was so happy to see this paper showing that the decline is not homogeneous as we think. It is heterogeneous, but because this was a population-based study, they really could not dissect out the reason. And of course, it was not a prospective study, so in that way. So they could not actually dissect out the causes why the eGFR fell in different ways in different people. Now, there are several screening studies done in India. This is one published in Kidney International about 9 years ago, where they looked at about 10,000 people in Chennai and Delhi. And they found that, if you look on the left Venn diagrams on the left, they found that abnormal HbA1c was present in a large number of patients, subjects, 79%. Of these, a significant number had hypertension, 54%, and 46% had both, and 11% had CKD. If you look at the Framingham risk scores, you find that the red is the bad news. So you find that between no CKD and CKD, the Framingham risk score increases. And we'll come to that again. So basically, if you have CKD, you are at risk, cardiovascular risk. Now, this is on the left. We are looking at eGFR decline in diabetes. And this is from a CAR study, which is a very large multi-center study, basically held by AIIMS Delhi, which initially even had patients from Karachi and other places outside India as well. Now, what they found is that there's a decline of eGFR on the left. And what they also saw is that whatever intervention was given to these patients, it didn't actually make any difference to the decline. The decline was basically the same. However, the usual care patients started at a lower level of eGFR. So at the end of the study, EOS at the bottom on the x-axis, the actual absolute GFR was less, but the slope was the same, slope of decline. And if you look on the right side, this is a canagliflozin study. There are studies with all the SGLT2s. You find that the blue line showing the decline with SGLT2, there's an initial sharp decline. That is because there's initial increased hyperfiltration when you give the SGLT2. And after that, of course, the blue curve becomes a much smoother slope. The reason I'm pointing this out is if you see at the bottom, the CAR study, the slope is minus 1.3 ml per minute. Whereas in the CANA study, the slope with CANA is minus 1.85. Without CANA, it is minus 4.59. And if you look at, say, the advanced study, which was many, many years ago using glycoside, there the decline of eGFR was minus 0.63. So there's a huge variation in the different studies that we come across in terms of diabetic nephropathy and its epidemiology and its progress. Now, again, in the CAR study, they looked at the prevalence of CKD in diabetes. They found it was 8.7%, which is actually similar to Norway. And there are other multi-center studies. There's a meta-analysis by Hassan, where they found that in India, it was 10.2%, Bangladesh 17.3%, Pakistan 21.2%. And then another person did a meta-analysis after 3 years with some more data, and he found that the incidence of CKD in diabetes was 31%. And again, you see the huge variation. And in a single center, my center, the incidence was 18%. Again, if you go back to my center, I looked at the patients who had an eGFR less than 55, somewhere between 1996 and 2004. And these patients had to have at least one visit per year. And by July 23, I had to know whether they were alive or dead. And there were just 71 patients. Of these, 39% were alive and 61% were dead. 5 patients opted for the hemodialysis option, 3 were dead. But the interesting part about the patients who did not survive is that almost all of them had macrovascular disease, and all of them had some comorbidity or the other. They were either smokers, or they had had a CNS bleed, typically subdural hematoma, chronic liver disease, NSAID, amputation, old polio for which there was pain and patient took a lot of NSAID and so on. So that was basically what I found. Now, by now you know CKD is bad news. So if you look at the different studies, again, there is a huge heterogeneity of the data. The data does not speak with one voice. The annual mortality in Singapore in CKD 3 to 5 is 6.4%. The 10-year mortality in the US, when you had no CKD, no DM, is 7.7%. With just DM, it was 11.5%. And then you had a double whammy, both CKD and DM, then you had 31.1%. And this is enhanced 3. And a diabetes patient on dialysis, basically hemodialysis, 5-year mortality is 72% in 1995 in Italy. It's come down to 65% in the US in 2015. But 65% mortality at 5 years is basically the best that we can do for a diabetes patient on HD. And the reason for that is in this slide, because it's a bit complicated. Basically, as your CKD progresses, the atherosclerotic CVD component as a contributor to death is less. And that is the yellow part, where you see that as CKD progresses, your atherosclerotic CVDs stabilize, whereas non-atherosclerotic CVD, sudden cardiac death, arrhythmias, and so on increase, which again makes it very difficult to treat or prevent. Now, there's a database called CRIC in the US. This has about 4,000 patients. Incidentally, Framingham started with about 5,000 patients. So it's a very impressive database. The funny part about the database is that it is sort of turning some of our cherished notions on their head. For example, bad news is male sex. You all knew that. It's always bad news. Increased urinary sodium, potassium, and oxalate excretion, use of heroin or opioids, being obese or sedentary, poor sleep pattern, non-adherence, of course, adverse genetics, I won't go into that, atrial fibrillation, hypertension, CHF, heart failure, low bicarb, high uric acid, and even hematuria. The interesting part, again, is on the right side, where they found that whether the care was by a nephrologist or not made no difference. If you were active, it made no difference. And in that study, they found tobacco, alcohol, and marijuana use made no difference. And this is a pretty big database. Good quality of life, self-reported, made no difference. Cognitive impairment made no difference. High lipids made no difference. Body composition made no difference. And surprise, surprise, whether you had retinopathy or not, whether it was stable or progressive, even progressive retinopathy made no difference to your outcome if you had diabetes nephropathy. So something to think about. And this is our long cherished eGFR. Now, what I'm trying to show here, don't have much time, is that as at the bottom is your estimated eGFR. And if you see if the eGFR is normal, there's a huge scatter between your calculated eGFR and the actual eGFR. As your eGFR declines, the two values, the calculated and the actual value, become more concordant. Ethnicity is an interesting issue. And you find that if you look at the number of patients on dialysis in the UK, the whites are 58 per million, whereas South Asians are 221 per million population. And of the 3% patients who are Asian on having type 2 diabetes, 7.7% have dialysis. Now, again, this is again showing the same thing. If you see on the right-hand side, Asian and Hispanics deteriorate more compared to whites and blacks. And this is a study done by Dr. Sujoy Ghosh, where they found that out of 110 patients, about 25% did not have diabetic nephropathy when a kidney biopsy was done. So to conclude, diabetes with CKD is a burden which is huge and growing. The mortality rises with duration of diabetes and with CKD stage. South Asian ethnicity results in faster progression without any difference in initial prevalence. There is a consensus on prevention, but exact figures are widely different between the different studies. Thank you.